Thanks. Renee just took 2 minutes of my talk. So if I go over, apology. I'd like to thank the chairperson and chair lady for the invitation. I'm really honored. I guess my affiliations have to change because I've resigned from AMPATH and I'll be moving to Cape Town shortly. And also partially will be involved, hopefully with Imperial College in London, to learn behavior change techniques on prescribers, and also behavior change regarding pharmacists and the behavior determinants of a particular person to make them an effective steward. Because not everybody is going to be good at stewardship. Might have the basic training, but the skills are quite comprehensive. So on that note, these are my potential conflicts of interest, although I'm not talking about drugs. And I would like to then, in the scope of this presentation, talk about several things regarding the pharmacist role, whether it is considering it, defining it, and supporting it, and then just talk about models for stewardship in infectious disease constraint settings, i.e., in Israel, for example, every hospital has at least 3 or 4 infectious disease doctors. One is in charge of stewardship, one is in charge of infection control. Even if you go to Argentina, which is a poorer country than South Africa, there are hundreds of them tangoing in Buenos Aires. If you go to Australia, where I was 2 weeks ago, they're inundated with infectious disease doctors. We don't have them, so what do we have? And I think based on my experience overseas, sometimes I think it's better not to have an infectious disease person running the stewardship program. And in my opinion, I think that the pharmacist would be better equipped if trained and empowered to not only initiate but maintain such programs with the help of infectious disease doctors. So on that note, much of what I have to say was published as an editorial yesterday, except the difference is, although it is fabulous to think that stewards will initiate, that pharmacists can initiate, even if they're non-specialized, non-clin pharm, non-ID pharm, can initiate stewardship interventions from an empowerment point of view, and therefore the hospital manager definitely wants you, and therefore maybe you'll get a higher salary. You can't do this alone, because stewardship also involves nurses to a greater extent, more than we at this stage cared to acknowledge. So the second paper, also in the same edition, yesterday looks at the French term esprit de corps, which is a term that relates to a shared goal, a sort of enthusiasm to attack or to help assist the issue of fighting AMR in South Africa. And this includes nurses. So Ronelle Pretorius is a specialty nurse in intensive care, and that role still needs to be defined. The pharmacist and the clin pharms are way ahead in certain aspects, even more than the medical schools and doctors, the nurses being sort of behind us, and the dental school certainly. The veterinary school is doing very, very well. As a matter of fact, next week I'm going to give a talk at the Pig Society, veterinarian, whatever. They are writing a protocol for an antibiotic guideline for use of antibiotics as growth promoters in pigs. So these people are really, really, really busy. And we started with a Twitter campaign asking McDonald's, when can we expect antibiotic-free burgers as they are offering in the US at the moment. So I'm not going to talk about about One Health. Ruth had already discussed it, and several of you. So from the point of view of stewardship, I think that we all accept that there's a need for wider engagement, because if you carefully look at it, it's multidisciplinary, and where you do not have infectious disease resources, or it is consistently supplied, like most of the hospitals in our country or even in sub-Saharan Africa, we need to find alternative people and equip them to run such stewardship programs. I also think when you teach stewardship as an undergraduate, and I'm not sure how you're going to find time to teach all the principles of stewardship in your curriculum, it's impossible. So your task as an output document is where do you stop regarding teaching, because you can't add an extra year for a B.Pharm. And do you restrict certain aspects of stewardship to clin farms, for example? And that is going to be your task as pharmacy schools. But there are certain principles that need to be taught. For example, how many pharmacists, even clinical pharmacists, understand the types of interventions? And the reason I'm talking about that is because persuasive interventions appear to be more sustainable from a stewardship point of view than a restrictive intervention. Persuasive interventions are used now in private practice, while in the public or academic sector, it's more restrictive. For example, the lab could block 6 antibiotics without giving the doctor the report. That means he can't use it. Or require pre-authorization, which some managed care companies wanted to do in South Africa, but I can't think that Discovery & Co. could give you permission to use meropenem or colistin before it's prescribed. It'll be impossible. And then you get structural changes. That kind of intervention involves from paper to electronic prescribing, which has got enormous problems when it comes to stewardship, etc. And when you look at efficacy of such interventions, you also need to teach the pharmacist or perhaps the clin pharms what kind of studies are done. Because you need to, if you don't measure it, you can't treasure it. So the way to do it would be either interrupted time series. I'll show you one that was done in Netcare, randomized trials, controlled clinical trials, before, after, etc. But it does look like persuasive interventions overall are more effective than restrictive and are more effective than actually having paper to electronic prescribing. So considering the pharmacist's role, this is a recent statement by the Infection Control and Hospital Epidemiology Society in conjunction with the Pharmacy Society of the US. And I'm not going to go into detail, but these would be, I assume, references for you to go forward. I'm going to leave the PowerPoint presentation on the screen, and anybody is welcome to take a copy. And if you need any of the studies, just email me and I will send them to you. So basically, if you look at the US at the moment, there are 5,000 registered hospitals, but only 400 pharmacists in all those hospitals with formal postgraduate stewardship training. So they claim then if an institution is unable to identify a physician or pharmacist with ID training, then we need pharmacists with formal stewardship training. And perhaps as a society you could consider online course for all your students to do. For example, my experience with the British Society of Chemotherapy's online course in stewardship is really, really very helpful. It's very easy. All students who want to qualify have to do the course, and we could design the course together. They do it after hours. They all got cell phones, I'm sure, smartphones, iPads, iPods. They can do it in the traffic. They can do it in the bath. It's only an hour or two a week for a few weeks. In any way, the point is we need to provide such pharmacists with the tools to do so. Now, I'm going to use this paper which looked at the critical role of the nurse, but what is interesting of the paper, it defines the different roles of nursing, microbiologist, the case manager, the pharmacist, the ID doctor, infection control, the inpatient doctor, and the hospital management. Specifically, where is the area where you would have an overlap between the pharmacist and the nurses. And this is important because when you design interventions, you need to understand that you need to incorporate them in such specific kind of stuff. This is the column for pharmacists. So this paper, which was published in 2013, showed the increasing role already in English pharmacists. But I'd like to give you, at that stage in 2013, compared to 2005, they did a survey of the skills. If you did a survey of pharmacists, of hospital pharmacists in this country, public and private, what are they doing at the moment? Because this would be very valuable to actually design policy from a council point of view. For example, and this is just measurement of DDDs, measurement of other measures such as days of therapy or LOT, which is length of therapy, and all the other ways other than DDDs can be taught to clin pharms. I don't think we need to expect undergraduate pharms. The US, by the way, is moving from DDDs to DOTs. But this is DDDs, and if you look at, and there were 281 pharmacists, hospital pharmacists, that at that stage participated. Only 80% of them could actually calculate the WHO DDDs per 100 patient beds. So this is kind of stuff, perhaps from a theory point of view, you can teach them, but I need to tell you there's a European CDC app which is available, and you just enter the stuff and you could do it automated. But the theory of how to calculate a DDD is quite important, although there would be an automated app. I also see that the International Pharmaceutical Association brought out this, where they issue new resource to arm pharmacies' fight against AMR. So when we define the role of the pharmacist, I think that we need to understand in teaching interventions that there are differences between teaching them in a care bundle, as Michelle from Life had shown you earlier, and also Angeliki, that we need to understand the theory of a bundle and the theory of change. What changes in a hospital? What changes in theory? Or what is the change of theory regarding bundles? Why do they produce better outcomes? Using a bundle or all or nothing composite measurement changes the way that care is provided, because it changes the assumption that evidence-based care from stewardship point of view has been delivered. They promote awareness that the entire team has worked together, and they promote the use of improvement methods. But another study looked at what are the key components if you as a pharmacist in your hospital are going to design a stewardship intervention, or you want to teach students how to do it practically, undergraduates. The bundle shouldn't be too big. They're independent, each of the measures. They have a defined patient population, so it's only pneumonia or only urinary tract infection. Or the lady from Tshwane presented something about primary care and sexually transmitted diseases. Keep it simple. A multidisciplinary team should develop it, and bundles should be descriptive rather than prescriptive. And compliance is all, or it's 95% compliance or none. So there are 4 criteria, however, that distinguish a bundle from a checklist, because the changes in the bundle are all necessary, all based on evidence, they're clear-cut, and the bundle changes occur in the same space and time. I'm not going to go into more detail. The only reason I'm going into that is a lot of successful pharmacists, non-specialized pharmacist interventions use the bundle concept. So we need to understand the theory behind a bundle concept. This is one study from England again, where the primary outcome measures was compliance with the care bundle, quality indicators, why did the doctor prescribe it, was cultures taken, etc., 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 whatever the intervention was, which was very, very significant in the sense that compliance to all of those was significant between the control phase and the implementation phase. Another one was designed in a high care unit. This was a little bit bigger. There was also renal impairment involved. These are non-specialized pharmacists. Documentation, therapeutic drug monitoring. Do they understand when to take the level? Call the lab or the nurse to take the level, or tell the nurse when to take a level, etc., etc. De-escalation, I think, is a tall order for an undergraduate pharmacist to understand. But anyway, the reason I'm talking about this study showed that 10 pharmacist interventions had to occur for one to be improved. So from a cost-effectiveness point of view, perhaps some of these could have been done by a nurse. And that interaction between the pharmacist and the nurse needs to be defined. It doesn't have to be 20 pages. It could be a simple one-pager in your output document. You could also design a 3-day bundle, which I'm not going to go into detail. Another one used unspecialized pharmacists to use the issue of prompts and a checklist as opposed to bundle. So they had these little stickers made, and when the doctor was told to please stop the therapy because it's too long, he had that kind of sticker, So prompts is a simple, effective way. There's several techniques that can be used, but I wonder if one should not consider, and we can talk about it after the talk, shouldn't a qualified hospital-based pharmacist perhaps, as a council, you should offer a short postgraduate course, which also could be online. Because many of these things can be discussed. It's easy to do. It's not a lot of time for them. Because, for example, the role of the pharmacist in the hospital in training young doctors how to use an antibiotic is an extraordinary opportunity which they're not getting at the medical school. And I'll give you 2 studies to show how pharmacists had impacted on outcome measures by targeting the young house doctor, by targeting the young registrar, and so on. There's a wealth of information that a pharmacist who's perfectly situated, at least in the 5 medical schools, to be able to impact on outcome. The most dramatic and most astounding one comes from this one, also 2016 in England, where the pharmacist gave feedback, the little group of pharmacists, to each of the junior doctors in the hospital, as a group and then individually. And what they did then with behavior scientists is actually construct a model of how the junior doctors' prescribing behavior is dictated. This is far more important than having a professor of infectious diseases give them a talk on antibiotic stewardship. So what do we need to support the role? Obviously, that's what the purpose of the workshop is. But Jackie Snedden is from Scotland and single-handedly as a pharmacist was responsible for the national Scottish campaign to get Clostridium difficile under control by by helping primary care doctors to stop prescribing ciprofloxacin to urinary tract infections and cut the Scottish cephalosporin use. She's the week 2 author of the online course. And what she did here was exactly the output document that I assume that you're working towards, because they did a survey, which is basically what you did in the previous 9 talks, by looking at the differences between the pharmacy schools of training in England versus the common aspects of undergraduate training, and then came up with a consensus document between the 9, I can't remember how many, a document which is a consensus training document for all the pharmacy schools in England that could be used as a base. If you wanted to adapt it to local circumstances in London versus Manchester, knock yourself out. But there was a minimum requirement that had to be done. I mean, a lot of you, or all of you, I assume, have the same basics as I gathered from the talk, but clearly there's differences in the practical application, which your consensus document could address. If the English can do it, we certainly can do it, taking into account the competition between the pharmacy schools, or maybe there isn't. But certainly in the medical schools there are, and the egos regarding entities of universities is big time in the medical school. Perhaps they're not so big in pharmacy, or I hope not. But either way, you need to look from a bigger picture on a national level what you will contribute eventually to the long-term future regarding resistance. And all those things like competition and size and egos need to be put aside, if that's possible. This is a very good document, and it was only published last year. So we're only a year behind the English when it comes to defining the minimum curriculum. Natalie and her crowd or colleagues at in MU in Pretoria, they looked at the knowledge, attitude, and perception of final year pharmacy students and found significant differences in the training. This was published last week in our journal, in the training between the different pharmacy students. Which is no surprise because it was very clear to me that the nine pharmacy schools had or the 8 had a different approach towards doing it. I think you can learn from each other because all of you had very good aspects of training which the other one might not have had. Anyway, the Clin Pharms are quite busy, or they already have a stewardship guideline for Clin Pharm training regarding pharmacist and stewardship in South Africa. They're actually further, you guys, than the doctors, because we haven't had consensus yet among the medical schools into what is needed from an undergraduate and a postgraduate level to train doctors regarding stewardship. And I suspect that you're going to be busy doing this in pharmacy schools before the damn medical schools start doing it, which is great news. In any event, it's the art of mentoring. Now, Mr. Chairman, ma'am, I'm nearly finished. Angeliki had already discussed some of models for stewardship where we don't have infectious disease resources. The reason I'm presenting the 3 Netcare studies in 2 minutes is mainly because I was based at Mill Park, which is sort of a flagship hospital of theirs. I'm not employed by Netcare. It just made sense. As our colleague from the Life Hospital group showed, they do stewardship, and also in Mediclinic, those kind of interventions, including those at the public sector, including those in the medical schools, it needs to be published because we need to understand and learn from each other what would be the best kind of study to do in South Africa. Just to come back to theory again, what is the use of theory? What is the actual theory regarding audit and feedback? And these are simple things that can be done in an hour in an online course with examples in a creative way. We used in the British Society a platform called Future Learn, which is a very strict thing. It's got little Q&As and it's interactive and it's got pictures. You know, a little bit, I'm not Generation X, as Renier said, or Generation Y, but the point is that these kind of platforms are there and it's very easy to teach certain things. But control theory postulates that the behavior change to a hospital or individual is most likely if feedback of one's performance is accompanied by comparison with a performance target. And behavior change is further improved by providing strategies, which is an action plan. What is the pharmacist going to advise the little stewardship team? What can they do to improve the stewardship intervention? So audit, there's some other data that shows it's more effective if the audit and feedback is delivered more than once, is verbal, written. All these kind of principles, I promise you we can incorporate in a very, very simple way for people to learn. So the first intervention is a collaborative driven by pharmacists, which used the Breakthrough series. This is the publication referred to. It's based on a point prevalence study. Do pharmacists know what a point prevalence study is? You need 10 minutes to teach them that. And this one was all South African intensive cares, and you'll see in private practice, inappropriate empiric antibiotics, de-escalation only practiced in 20%, and duration was excessive in 80% of prescriptions, and these then formed the basis of a low-hanging fruit intervention. More than 4, more than 7 days, etc. So one of the hospitals in Cape Town took this in a literary way. So bananas was more than 14 days, and apples was redundant cover, 2 anaerobe antibiotics, 2 MRSA antibiotics, but in any event, the point is, does telling, in this instance, hospitals what they've been doing change what they do? The collaborative model is key because the pharmacist was driving it. Report back after permission on a toolkit to the product manager who provide monthly feedback and improvement to the pharmacist, who then provide feedback. So the key of this study and why it was published in the Lancet Infectious Diseases, it was driven, and the recruitment, the multidisciplinary collaboration, coordination was done by non-specialized pharmacists who had never been trained in undergraduate level. So if this is possible, then certainly you have an amazing opportunity to affect change in your training module. Both studies, I'm going to get to the other one now before I conclude, said, oh, but this was done in 47 private hospitals. How about the public sector where the majority of people get care? And we did include that you don't need extra money to do it. You just need to have the backing. So we currently have an ethical process on the way to do a community-acquired intervention in both public and private sector to teach the principles of audit and feedback in both sectors for people who haven't participated. That was a reduction in overall consumption in 130,000 patients on intravenous antibiotics. This is what I'm going to study at the Imperial College. So the pharmacist had to intervene for about 65 months. But after about 1 year and 3 months, the doctor didn't prescribe more than 7 days anymore. He didn't give 2 anaerobe antibiotics. You have to add flagyl, to every infection. They didn't have to say, where's the cultures taken? Why are you giving more than 14 days? They stopped the doctors in that group, and there were 5,000 specialists, had stopped doing it. The pharmacist didn't have to intervene anymore. What was the behavior change that the pharmacist had caused, non-specialized pharmacist, without training in psychology? What had happened that the doctors stopped doing these kind of things, excessive treatment? The implication was, and this is the conclusion in the paper, that the role of the non-ID in promoting interdisciplinary engagement and nurses, doctors and nurses in programs or across health systems like this group cannot be underestimated. Cannot be underestimated. We never would have got that far if we had ID doctors. This is another study which will be published shortly. It's perioperative prophylaxis. Michelle briefly went through it. You think that perioperative prophylaxis is easy. You're making a mistake. Surgeons are impossible people. It's not easy to work. How do you equip a pharmacist to work with a pharmacist, to work with a surgeon? And I'm causing this higher hanging fruit than the initial Netcare intervention, because as this elephant is trying to get hold of Marula, we're talking about behavior change such as uncertainty avoidance. This is from Europe, where individualism and power distance. Do you know what is power distance? I am the surgeon. You are the pharmacist. You the nurse. You are there. I have an MB-CHB and an MED and a whatever. How dare you tell me that I need to give the antibiotics differently, and I can't give the antibiotics until the drain comes out, and it's not one dose will cause a post-operative infection, etc. These are the barriers which I'm going to conclude with. But that's the study in 34 hospitals in Netcare. I just want to go to the compliance. So the antibiotic choice increased to above 90, the dose above and nearly 90%, duration improved significantly, and overall compliance. But look what happened with antibiotic timing. And the reason I'm talking about that, it is ironic that was the mean surgical site infection rate which decreased. It is ironic to me that we had more than 90% compliance with surgeon-dependent measures. Surgeons changed their behavior with pharmacists telling them, our protocol says 1 dose, you can't give more than 2. This is what you need to use. The gynecologist wanted to use Rocephin. No, it's Kevzol. They wanted to use 1 gram. No, it's 2 grams. Based on the Netcare guideline, which is based on international guideline. Well, what we couldn't get right was the increase in timing. So there were changes that occurred, and this is action planning. How do you deliver the antibiotics? In fact, during Angelique's visits on site, do you know why timing indicator was only 60%? Because nobody recorded the incision time. And the measure says that you need to get the antibiotic in 60 minutes, within 60 minutes of cutting the patient. So stewardship for pharmacists involves a little bit of more practical knowledge, and therefore we need to, in a collaborative way, teach them. I just want to add to this. The study emphasizes that institutional delivery are critical to stewardship interventions, and the fundamentals of drug delivery are as important as the doctor-dependent measures if we are to improve care. Who is best suited to improve the institutional delivery of an antibiotic in such an intervention? Not the IPC, not the manager, not the ID, it's the pharmacist. In this case, we used surgical nurses to improve. Angelique already spoke about the improvement in hang time, which also involved nurses. So I'm going to conclude with the barriers. I don't know what the barriers are. I don't know if you as the 9 schools should study this together. I could help you with such a protocol. But what's the current, we call it CAP, knowledge, attitude, perception of antibiotic management of qualified pharmacists that have already passed through your schools? Do you have a responsibility to get them on par with stewardship? I'm not sure what your mandate is. What's the current involvement of pharmacists in hospital or primary care? What's the role of the retail or community pharmacist? This is an area which we have not addressed yet. What will it take to develop a consensus expert curriculum? What are the required skills? I think 2 or 3 of you had discussed this in your short presentation. To implement, maintain, participate, and what are the social prescriber constructs that are relevant to stewardship? I will study that so that we can teach the students. If you have a doctor who's difficult, that I just did a heart transplant, you can't tell me what I need to do. What are the skills? What are the behavior change techniques? Research is moving towards that, but perhaps it would be too much. Just one more paper, Mr. Chairman, ma'am. This is a brilliant paper. What are the skills required? Knowledge and skills. I'll summarize it for you if you wish for your consensus output document in 3 paragraphs. But there are skills beyond infectious diseases, beyond microbiology, that are critical. These are the knowledge of quality improvement principles, how to measure them, how to measure consumption, and behavior change. So in conclusion, the first program published was at UCT. This is a Mendelssohn & Co. initiative. Mark Mendelssohn is a fabulous teacher. He's also the sort of political co-chair of SASP. I'm more quiet, behind-the-scenes, practical person. But it's difficult to replicate such ID resource rich kind of models. We don't have it, so we use pharmacists. So it's therefore critical in this context to utilize existing resources, including nurses. But the models presented here attest to the fact that stewardship can be introduced, and we need to teach undergraduates how to do it. But either way, for me, standing from a SASP hat point of view, the potential for pharmacist-led models to complement that of clinician affords an exciting opportunity in this country to offer an integrated range of stewardship models that can serve the whole population. What we do need to know is to understand the barriers and a contextual understanding, and one of them would be undergraduate training. So thank you very much.